In May 2021, health organizations were processing millions of data points a minute to track the global spread of COVID-19. Yet, looking at the reality of an individual doctor that same day, you find a highly trained professional spending hours clicking through repetitive documentation screens. The broader economy has already made a crucial transition. Modern markets place their highest value on intangible intellectual capital and knowledge, rather than physical, tangible assets. Healthcare has been markedly slower to embrace this transition. Compared to other knowledge-based industries, medicine's adoption of information technology has lagged by decades. This creates a severe paradox. We possess the processing power to deploy predictive AI and analyze big data, but the healthcare workers actually treating patients are experiencing deep moral distress, trapped navigating clunky legacy interfaces. The pressure to modernize forces healthcare organizations to act quickly. Instead of analyzing how an innovation fits with existing technology, administrators often simply plop a new system directly on top of old, incompatible clinical workflows. Successful health information systems, or HIS, adoption requires a different approach. We must deconstruct historical architectures, understand the behavioral science of diffusion, and calculate the unintended consequences. When organizations fail to align new technology with human-centered processes, the result is exact and measurable. Physicians are turned into data entry clerks, and patient safety is actively jeopardized. The origins of healthcare IT date back to the 1960s. The first systems were built by hospital data processing departments, and they had a singular, specific purpose: patient billing and charge capture. The first attempt at a comprehensive medical information system didn't even originate from a hospital. It was designed and built through a federal grant by the aerospace and defense company Lockheed Martin. By the 1980s, the introduction of air-cooled mini-computers significantly reduced hospital infrastructure costs. This allowed more competitive vendors to emerge, and financial software became affordable for a wider range of hospitals. This era gave rise to the first professional IT organizations, such as the Hospital Information Systems Sharing Groups and the Electronic Computing Hospital Organization. The Health Information Management Systems Society, or HIMSS, also traces its roots to this period. It began in 1962 as a management engineering group and evolved into a massive, not-for-profit analytics database. We also see the American Health Information Management Association, which began in 1928 as an association of record librarians. Today, it provides strict accreditation tests for health information professionals and coders. Meanwhile, the American Medical Informatics Association was formed with a very specific mandate: to promote the science and practice of medical informatics, focusing on the data itself. And the Alliance for Nursing Informatics was established to connect 18 independent nursing groups, focusing on professional development and collaboration. These origin points reveal a structural problem. The modern alphabet soup of professional organizations and existing HIS architectures were built on deeply entrenched financial roots and siloed disciplines. They were never originally designed for clinical patient care. Understanding how disruptive HIS actually integrates into a highly stressful clinical environment requires a behavioral framework. In 1962, E.M. Rogers conceptualized the theory of diffusion of innovation. This chart shows Rogers's adoption curve. On the left are innovators who initiate change. Next, early adopters use that experience to make decisions. The early majority cautiously embrace the innovation, followed by the late majority. Finally, traditional laggards resist altering legacy workflows. In 2009, the federal government bypassed the natural pace of this curve. The HITECH Act offered financial incentive payments to healthcare providers, effectively forcing the rapid adoption of electronic health records through meaningful use criteria. The stated goals were clear: improve the accuracy and availability of clinical data, allow providers to anticipate diagnostic needs, and empower patients to participate actively in their wellness. A clear case study of success is the U.S. Department of Veterans Affairs. Despite spending proportionately more than private sector systems, the VA used a deliberate, organized implementation strategy to achieve high adoption rates and high-quality care. Technology adoption is not solved by simply purchasing software. It is a predictable behavioral science. Realizing the benefits of a new system depends on creating measurable objectives and ensuring strategic alignment across the entire organization. To prevent organizations from haphazardly stacking technologies, HIMSS developed the Electronic Medical Record Adoption Model, or EMRAM. It serves as a roadmap to evaluate system maturity. The EMRAM roadmap tracks 8 stages of adoption. Stages 0 and 1 are baseline ancillary installations. Stages 3 through 5 require significant workflow shifts, like structured physician documentation. Finally, Stage 7 achieves a completely paperless record and advanced data analytics. Detecting the effects of automation often lags behind implementation. The drive to reach Stage 7 generated severe unintended consequences for the people doing the work. A 2012 study revealed 44% of medical errors were human, but 56% were directly related to computer systems. A 2018 Stanford report detailed the toll. Physicians now spend 62% of their patient time doing nothing but documenting in the EHR. Independent research by KLAS confirms the resulting frustration. Across the industry, less than half of physicians feel their EHR systems actually enable them to deliver quality care. This operational friction stems from an education gap. The vast majority of clinicians and health managers have no formal education in informatics, leaving them unable to effectively oversee the vendors selling them these products. Vendor contracts routinely prioritize rigid assembly line workflows over human-centered design. When software gets in the way of provider-patient interaction, highly trained clinicians are reduced to data entry clerks. The solution requires moving away from treating the physical hospital as the center of the healthcare universe. Organizational models must transition from strict hierarchies to flat, adaptable social networks. Digital technology is dematerializing information. It separates vital intelligence from central records rooms and corporate offices, taking physical geography out of the equation entirely. We can see this in market investments. Funding for saturated, provider-centric tools is diminishing, while capital flows toward patient-centric technologies designed to engage individuals in managing their own health. A working example of this predictive care is the Mayo Clinic's AI-guided ECG screening program. Researchers utilize distributed computing tools like Hadoop to link relational databases and process tens of millions of electronic patient records. This massive dataset is what makes training the AI algorithms possible. Using relatively inexpensive electrocardiograms, the AI discerns electrical signatures that the human eye cannot see. It accurately calculates the probability of atrial fibrillation before a patient ever feels symptoms. Predictive tools like this change the core function of medicine. They shift the focus from acute care inside a hospital to lifelong, preventative care managed through accountable care organizations and personalized medical homes. Mobile health, or mHealth, accelerates this decentralization. We now have smartphone-based COVID-19 testing utilizing nanoparticle chemical glows and Bluetooth proximity warnings to trace viral spread. Remote patient monitoring utilizes biosensors to track patient vitals continuously from home. Cloud-connected systems flag abnormal readings in real time, allowing physicians to intervene without a clinic visit. But as the network expands, so does the risk. Healthcare platforms are increasingly targeted by ransomware attacks, aiming to disrupt clinical care on a large scale, turning these vulnerable new endpoints into direct threats to patient safety. Expanding tracking applications also requires strict ethical boundaries. Using geolocation and Bluetooth data for population monitoring demands rigorous adherence to privacy laws to ensure personal freedoms are protected. Navigating these risks requires organizations to mature past basic transactional systems and invest heavily in the upper quadrants of the HIS framework, clinical and business intelligence. Adopting technology for the sake of newness achieves nothing. The objective is to manage knowledge. By aligning intelligent, human-centered systems with the actual realities of clinical work, we can unburden the provider, decentralize the data, and elevate the standard of patient care.